All right, good morning, everybody. Welcome to the special meeting of the EQIP committee. And today we're doing an EQIP question and answer session, and we're going to be going over reporting as well. And very exciting today because although many of you probably have dealt with them on a one-on-one basis, this is their debut in speaking roles at these meetings. So we're going to hear from both Olivia Simon and Crystal Forte. So Olivia works for MedKai. She's an EQIP practice transformation specialist and is just finishing up or about to finish her master's in healthcare management at Stevenson University. And Crystal has completed her master's from the University of Baltimore, University of Baltimore County, UMBC, in health informatics, and is a program analyst at CRISP. So I know a lot of you have probably talked to them over the course of time or had them help you on a one-on-one, but we usually we haven't let them present. So they're going to be doing that today, and they're more than ready and able. And then, of course, we have Jessica from CRISP, who always does a great job and knows more about this program in CRISP than many of us have ever known. So you could not have a better crew going through the question and answer today. So having said that, I am going to be quiet and turn it over to Crystal to kick it off and answer all your questions about EQIP and how to report and how the system works. So Crystal, it's all yours.
Thanks so much, Jean. Good morning, everyone. Happy Friday. Thank you for joining us here for our EQIP Q&A session. So today we're going to be talking about all things EQIP. So our focus will first start off on the EQIP background, things like the participation requirements, our PY4 episodes, the episodic value-based payment, our quality metrics, the incentive payment methodology, as well as our EQIP timeline. Then we'll go into the Q&A session. So we have some submitted questions by providers, but we'll also have times for you guys to ask any live questions that you may have. And then we're going to go to our reporting webinar, and where Jessica will walk through our EEP portal. So Jessica, if you could go to the next slide. Awesome. And we're going to get started with our EQIP overview and a little bit of our background. So the Episode Quality Improvement Program, or EQIP, was essentially first created because CMS excludes Maryland providers from participating in certain Center for Medicare and Medicaid innovation models. So in order for us to make sure that every practitioner has access to value-based care and advanced payment models, the HSCRC, which is the Health Services Cost Review Commission, created a voluntary episodic incentive payment program, which is known as EQIP, and that was made in 2022. So EQIP was the first specialist-focused program designed to achieve cost and quality savings, both in and out of hospital settings. Jessica, if you go to the next slide, please. So EQIP was specifically designed to emphasize financial accountability, care redesign, clinical data analysis and feedback, practitioner engagement, as well as patient and caregiver engagement. So EQIP provides incentive payments to practitioners to essentially help achieve these goals. And these incentive payments are based on both financial performance within the program, as well as quality performance for those participating providers. And the great thing about EQIP is that it was designed for the practitioner to have full ownership. So there is only an upside risk to participating. Another great aspect of EQIP is that it's recognized as an advanced alternative payment model, so it exempts practitioners from reporting MIPS. And I'll pass it over to Olivia to review some of our participation requirements.
Thank you, Crystal. Okay, so like she said, I'm going to start off by reviewing the participation requirements. So first, you must qualify as a care partner with CMS. This means you must be licensed in Maryland and enrolled in the Medicare provider enrollment chain and ownership system. And you must use a certified electronic health record technology and CRISP, which is Maryland's Health Information Exchange. Then you must enroll in EQIP. This includes establishing an EQIP entity, selecting episodes and interventions, agreeing to quality metrics, signing a care partner arrangement, and then determining a payment remission recipient. Finally, to participate, you must meet episode thresholds. For a single episode, the threshold is 11 episodes in 2019, which is EQIP's baseline year. And then across all episodes of participation, the threshold is 50 episodes in that baseline year. If you can go to the next slide, Jessica. So now we're going to look at the performance year 4 specialties available. So for performance year 4 or calendar year 2025, EQIP is going to utilize the patient-centered episodes of care system, or PACEs, to define a clinical episode. So here you can see a list of all of the episodes available through EQIP for this upcoming performance year. While these episodes are central to the following specialties, there is no limitation to the type of specialist who wishes to enroll in EQIP under one of these episodes.
Awesome. Now we're going to touch on a little bit about the episodic value-based payment. So essentially, practitioners will continue to get full fee for service payments. And then in addition, EQIP allows them to earn a portion of the savings they create through better care management. So the first step is the practitioner is going to sign up for EQIP, like many of you have, and agree to an arrangement. So the care partner will then enroll in clinical episodes that will trigger when a specific procedure or treatment is performed. Then using the baseline period, which is the calendar year of 2019, the cost for the selected episodes will be calculated to identify an appropriate target price. And at the end of the year, performance is going to be assessed by comparing the cost of the target price to identify if savings were achieved and if participants are eligible for those incentives. And then we'll go to the next slide. So our EQIP quality measure selection. There are 3 EQIP quality measures, which those are advanced care planning, documentation of current medications in the medical record, and preventive care and screening around body mass index, screening in a follow-up plan. So these 3 measures will be the same regardless of the practitioner's specialty and regardless of the episodes that each EQIP entity chooses to participate in. So EQIP quality metrics are evaluated through claims data. So for each attributed episode, the HSCRC will assess whether the 3 quality metrics were performed by any practitioner within the year preceding the end of the episode. So therefore, with these measures do not need to be performed by the triggering care practitioner specifically, but rather we want to incentivize the coordination across the care continuum with other practitioners who might more frequently provide these services, such as a primary care provider. And the last part of the quality metrics to remember is that these are based on Part B claims. So it's important for these measures to build all these measures by tracking the appropriate CPT codes. And then Olivia is going to touch more on the incentive payment methodology.
So there are 5 main steps to determine the incentive payments that are due to the EQIP entities. The first step is to assess the performance period results. At the end of the performance year, the HSCRC will assess the results seen across the episodes in which the EQIP entity is participating. If the aggregate costs across the EQIP entity performance period are less than the target price, savings will be achieved. In addition, the EQIP entity's program year savings must meet or exceed 3% of its aggregated target price before it is eligible to receive incentive payments. This is to ensure that savings are considered statistically significant. The second step is to determine the shared savings. The savings will fall into one of 3 tiers. Using the baseline data, EQIP entities will be compared using the statewide experience and ranked on efficiency. For example, the higher cost practitioners are ranked in the lowest tier, meaning 50% of their shared savings will be due to the EQIP entity, while 50% will be retained by Medicare. As Crystal just mentioned, quality is a very important component to EQIP, which is why the third step is to consider the clinical quality score. To ensure the outcomes of the program are not at the cost of patient outcomes, 5% of the shared savings will be withheld pending assessment on the 3 quality metrics. The performance on these quality metrics will determine how much of that 5% is earned back by the entity. The fourth step before shared savings are paid out is to check the incentive payment cap. The state must confirm that the calculated payment is no more than 25% of the prior year's Part B payment. Once steps 1 through 4 have been completed, the HSCRC will direct the CRP entity to pay the incentive payment to the EQIP entity. This will be paid in full as a lump sum payment 9 to 12 months after the end of the performance year. To clarify, this is just one payment to the EQIP entity, and any distribution at the individual care partner level will be left up to the EQIP entity. Next slide, Jessica, please. So the final component that we wanted to review today is the EQIP timeline. And so practitioners will have an annual opportunity to enroll in EQIP. So listed on the screen in front of you is just a general overview of this EQIP timeline. The enrollment period will be open July through August of each year before the upcoming performance year. So for example, performance year 4 or calendar year 2025 enrollment for performance year 4 took place in July to August of 2024. Following enrollment from September to December, care partners who have enrolled will then be submitted to CMS for vetting, eligibility auditing, and contracting. Enrollment will be finalized once care partners return their signed care partner arrangements. January 1st will officially mark the beginning of the new performance year, and it will run until December 31st. Finally, any earned incentive payments will be distributed 9 to 12 months after the end of the performance year.
Awesome. Thanks, Olivia. So we're going to go a little bit into our Q&A session. So we're going to start off with answering some questions about the key players who participate in EQIP. Awesome. So the first question is, what is a care partner? So a care partner, they are general practitioners, specialists, or other CMS approved practitioners who are enrolled in EQIP. And our next question is, what is an EQIP entity? So an EQIP entity is an individual care partner or a group of care partners that have enrolled and will be participating together in EQIP. Our next question is, what is an administrative proxy? So an administrative proxy could act as a practice manager, an external consultant, or whoever the entity would like to engage with to help them manage participation and monitor performance within the EQIP program. The next question is, what is a care redesign program entity? So a CRP entity is responsible for aggregating the care partner arrangements and issuing incentive payments for the payment remission source indicated by that specific EQIP entity. So the CRP entity for EQIP is the University of Maryland Medical Center, also known as UMMC. And our last question for the key players slide is, what is the difference between HSCRC, MedChi, CRISP, and how are they all related and what are their roles? So HSCRC and CRISP are both EQIP program administrators. So we facilitate enrollment, calculate episodes, monitor performance, maintain reporting requirements, and determine incentive payments. MedChi works closely with the HSCRC as well as CRISP to support EQIP and its participants. MedChi has also helped create EQIP entities specifically for practitioners who may be ineligible to participate on their own, and so MedChi will serve as an administrative proxy to them. And then we're going to ask some questions or answer some questions about the PACES episode grouper. So first, what is PACES? The PACES is the patient-centered episode of care system. And so this is the episode grouper for the EQIP performance year 4, which is the calendar year of 2025. So PACES consists of over 1,090 episodes that are grouped into clinically relevant areas. And this is procedural, chronic condition, and acute condition. And a question that we've received a lot is, why did EQIP switch from Prometheus to PACES? So first, while many PACES episodes are undergoing final clinical review and updates, PACES provides a much more complete coverage in comparison to Prometheus and paves the way for an easier, more seamless program expansion in future years. Current EQIP episode categories are well covered by finalized PACES categories, and overall, a high degree of alignment has been found for episodes currently available under EQIP. Our next question is, what is the process to add new EQIP episodes? So a list of all available PACES episodes will be circulated, and stakeholders can reach out to equip@crisphealth.org to request a new episode to be added to the PACES grouper. And then our last question for this slide is, where can I find more information on PACES? And here we've included a link, www.pacescenter.org, where you can find all the information you would like about PACES. And then once this slide deck is circulated, you can feel free to just click on there. And I'll pass it over to Olivia to discuss a little bit about the EQIP methodology.
Thanks, Crystal. So the first question we have is, what data is used for EQIP? So EQIP is Maryland Medicare only. Data is obtained from the Claim and Claim Line Feed, or CCLF, and is only inclusive of Part A and Part B services. There are some additional exclusionary methodologies that you can reference on this slide. The next question is, how does my data get into EQIP and hence get to Medicare? So the episode triggers and episode relevant costs are obtained from Medicare fee-for-service claims. There are no additional reporting requirements for EQIP participants. The next question is, how are EQIP episodes triggered? Each EQIP episode has a different definition that uses clinically validated codes. EQIP episodes are triggered by the submission of a claim for a specified relevant procedure and/or diagnosis through one of those qualifying trigger codes. And a link to the Performance Year 4 episode playbook can be found right there on this slide. The next question is, what costs are included in EQIP episodes? So both Medicare Parts A and B claim payments for the beneficiary for services that are rendered during the episode period and defined as relevant according to the PACE's episode grouper. The next question is, how is the target price calculated? An EQIP entity's target price is calculated by determining the average total relevant episode cost among all clinical episodes attributed to its care partners during the baseline period for each enrolled clinical episode category. The preliminary target prices are available at the start of the program year. However, the final target prices that will be used for reconciliation will not be made available until the end of the program year after inflation adjustments and standardization have been applied. Next slide, please. So we're going to continue with some methodology questions. So the first one is, if there is a patient that is seen by an EQIP participating provider that is eligible for 2 enrolled episodes, which episode will their care be attributed to? So PACE's services assignments uses a pre-established hierarchy order. Procedure episodes are considered the first priority, then followed by acute episodes, and then chronic. If both of the episodes fall under the same category, PACES will then decide the episode based on the service type and other rules that they have in place. The next question is, if a doctor in a different entity submits a claim for a patient triggering an episode, and we see that patient for the same diagnosis 2 weeks later, is that episode only attributed to the doctor who first saw the patient, or is our entity now involved in the episode? So for procedure and acute episodes, the attribution is assigned to the practitioner who first opens the episode, and then subsequent visits would be included in the relevant costs of that episode. For chronic episodes, attribution is determined at the end of the year based on the plurality of E&M visits.
Now we're going to get a little bit into our quality metrics aspect of EQIP. So the first question is, what CPT codes are required for each quality metric? So as mentioned before, these are the 3 quality metrics, advanced care plan, current medications, as well as body mass index. And here we've included a link to the CMS guidelines for each of these quality metrics. So once you all get these slides, you can feel free to look into this a little bit more. The next question is, when doing these quality measures, do they need to be done each time the patient comes in, or at least once a year? So for each attributed episode, the HSCRC will assess whether the 3 quality measures were performed by any practitioner within the year preceding the end of the episode period. The quality metrics only need to be billed once to get credit. Our next question is a question that we've seen multiple times. Do quality CPT codes need to be submitted at the same time? Can the quality CPT codes be submitted with any claim in 2024, etc.? So we've gotten a lot of questions about CPT codes specifically, when they need to be submitted and by whom. So as mentioned previously, the HSCRC is going to assess whether the 3 quality measures were performed by any practitioner within the year preceding the end of the episode period. And once those get billed, you'll get the credit. So the last question on this slide is, what if I typically record quality metrics in other ways? So EQIP quality metrics are measured through claims data only. So other methods of reporting quality will not satisfy EQIP requirements. And then Jessica, perfect, thank you. The next question on incentive payments. So is the incentive payment a lump sum payment? So yes, the incentive payment will be paid in full directly to the payment remission source indicated by that specific EQIP entity. And then our last question on this slide would be, when would I get my incentive payment? So typically incentive payments are distributed 9 to 12 months after the end of the performance year. So the incentive payments for PY4, which is this upcoming calendar year of 2025, will be expected around fall of 2026. And I'll pass it over to Olivia to discuss our savings policy.
Thanks, Crystal. So the first question I have is, how would savings affect my practice? So there are 2 main ways that savings would affect an EQIP entity. The first is EQIP's savings policy requires EQIP entities who generate savings to offset those savings in the following program year prior to earning an incentive payment. Second, an EQIP entity will be removed from EQIP if it generates savings in 2 consecutive program years and its baseline period performance across all clinical episode categories in which it participates ranks in the lower 2 terciles of the tiered shared savings rate. The second question is, if my entity is removed from the program for 2 consecutive years of savings, can my entity re-enroll in future performance years? Yes, the MPIs associated with an EQIP entity's 2 consecutive years of DIS savings will be required to leave EQIP for at least 1 performance year. After that year, those NPIs will be eligible to re-enroll in EQIP. Next, thank you. So now we're going to talk about removal from the program. So the first question is, why would an EQIP entity involuntarily be removed from EQIP? So EQIP entities or care partners may be removed from EQIP if they do not maintain vetting and certification from CMS, or if they do not comply to the care partner arrangements. As mentioned on the previous slide, EQIP entities in the lower 2 terciles of the tiered shared savings rates that generates 2 consecutive years of DIS savings will be removed from the program. Lastly, if an EQIP entity is below the 20th percentile threshold for a single quality measure, the EQIP entity will be on probation for the performance year. 2 consecutive performance years on probation will also result in removal from EQIP. And then the next question is, can care partners withdraw from EQIP during the performance year? So essentially, no, EQIP entities or care partners cannot withdraw during the performance year. But if you have any questions or concerns regarding this, please reach out to equip@crisphealth.org.
Now we're going to discuss a little bit more about MIPS. So a question that we often get is, am I exempt from MIPS? Am I exempt from reporting MIPS if I'm in EQIP? And what if not everyone in my practice is in EQIP? Do they still have to report? And the answer to that is practitioners who are enrolled in EQIP are considered qualifying APM participants, or QP, and therefore they are exempt from reporting MIPS for the calendar year or years that they're engaged in EQIP. Any practitioners that are not in EQIP may be still required to report MIPS, though. And then our last question is, are there negative consequences to reporting MIPS while being in EQIP? Reporting MIPS while being in EQIP will not have a positive or negative impact on practitioners. So practitioners who are in EQIP will not benefit from MIPS, even if you do report that. And then, sorry, this is our actual last question. How can I check my QPP status? And here we've included a link to the CMS website, and this will take you to the QPP participation lookup, and you can put your NPI in there and see your status. And now I'm going to turn it over to Jessica, who's going to present our live session. So please feel free to come off mute and ask any questions that you may have about EQIP that we may have not touched on, or if we did touch on, feel free to just clarify, and I'll pass it over to Jessica.
Yeah, Olivia, Crystal, thank you both. You did a great job echoing. If there's any questions in the chat, I think I just saw one, which Jean answered, but I think it's worth just repeating for the group here. There was a question if Medicare Advantage beneficiaries are included, and the answer is no. So Medicare Advantage or other health arrangement groups are not eligible for EQIP. They're not really part of the model in general for TCOC, which is why they're excluded here. So it's typically just straight Medicare fee-for-service. And while we wait for questions to come in, if there are any, I also want to plug both the MedChi and the CRISP website, which has a ton of information, past recordings. We're happy to answer individual questions, but the policy guides that go more in depth about this methodology would be available on that site.
I do see one question in the chat, Jessica. Is there ever a situation when the APM participant is not a full QP and rather a partial QP, which would support submitting for MIPS for that partial QP status?
For EQIP, no. By enrolling in EQIP, you would not be a partial QP, you'd be full QP status. Again, that's specific to EQIP. Other programs may not be the same. Well, Olivia and Crystal did such a great comprehensive job. We're not seeing any questions come in. You can feel free to add them, but I think at this point, we will pivot to the reporting webinar section of this. Give us 1 second, we'll switch over.
While we're switching over, one thing I did want to comment on, I know a lot of the folks on this call are paying attention as Maryland is talking about moving forward on ahead. It was announced that the total cost of care by John Crum that as long as things proceed, and we can never have 100% until the contract's signed and everybody agrees to it, EQIP will not change in ahead. It is right now one of the terms where both the parties have agreed to keep it moving forward the way it is. So that's good news. So anybody who was concerned there'd be major changes to the program under the new model, it looks like as long as the new model goes forward, we're going to be continuing to operate in the way we've been operating for the last 3 or 4 years.
Hi, Jean. This is Dr. Erica Sima. I have a question. I was muted, so I don't think anyone could hear me when I was trying to speak. Sorry about that. I'm not sure, I don't understand or use all the right terminology, but I'm gonna try to phrase my question to so that you can understand it. But given that multiple practitioners may be involved in an episode, because what I understand is that an episode is triggered by the first person, I guess, who opens that episode. And then the patient might be seen by another provider like 2 weeks later. But so given that multiple practices might be involved actually in an episode, is there any concern that attribution may be going to the wrong person? I don't know. Like one person has a savings, one person involved in the episode might create a savings, one person might create a savings. How is that handled? I'm just concerned about like how the attribution is done.
So for each bundle, the attribution is very clearly set to a specific CPT code. So if you bill that CPT code, that patient is being attributed to you. Your concern about other costs is really important, obviously, because you're managing that bundle based on that CPT code for everybody's costs related to it for the period of time of the bundle. So for example, if you're doing a bundle where it's 180 days, you bill the CPT code that triggers the bundle, that's yours. If that patient goes to 8 other doctors and some of them really run the costs up, then that's going to count negatively towards the costs and the target. So I don't think there's an attribution problem with this because unlike some of the other models where they look at several factors to determine attribution, this is very specific. And you can look at which bundles you've selected to participate in, and you can see, okay, so if I trigger this CPT code, it's mine. And maybe you'd want to consider some interventions to make sure that that patient doesn't do anything like crazy, like go to the ER 6 times, right? So the concern is not tied to attribution. The concern is tied to cost that you're worried about, and it's a legitimate concern. And that's why you really want to think about, which bundles you're in and talking to those patients when you're seeing them. So you can say, hey, if you have a problem, call the office. We have somebody who can talk to you. You can think about it, and you'll know more about that than I am because you're a physician and I'm not. So I don't know, Jessica, if you or Olivia want to add to the question or anything I said.
Yeah, Jean, I think you did a really good summary of this. I will add that the main reason there's a difference between our procedure and acute episodes and chronic is because of some of that concern. So for chronic episodes where the first person that opens the episode, and it goes the whole year, it goes till December 31st of that year, may not be the one that's primarily responsible. That is why attribution just for our chronic episodes is determined at the end of the year. And we essentially look at who touched that patient the most, and they're the person who gets assigned the episode. For a procedure and acute ones, the logic is a little bit more straightforward. If it's a surgery, the surgeon is going to be attributed. It's kind of that first event. Clinically, the decision for the paces, it made sense to provide the attribution that way. Again, chronic episodes is slightly different, and I think the concern is very valid, and that gets brought up. And for users that are looking at the performance data over the year, you may see some of that chronic attribution change as you get more data. Again, as that patient, may start seeing someone and either establish with specialist or establish with a primary care, it could potentially change. But we believe that the attribution kind of answers that, but knowing that it isn't only going to be a single practitioner that's ultimately accountable for all the costs in any episode, regardless of the type. There is going to be a lot of coordination and hopefully interventions that the practices or the practitioner can do to avoid really unnecessary utilization.
Okay, thank you.
And for anybody on the call who needs to see what bundles are included or what the trigger episodes are in the bundles they've selected, they can reach out to Krista or Olivia and they can send information on the specific bundles if you haven't done that.
That's okay. I think you're okay. Perfect. Yeah.
Yes, okay, so thank you for your questions. With that, we're gonna move to the reporting aspect, but feel free to ask questions towards the end of this, whether related to the reports that we review here, or anything else related to like the methodology or the policy. So this is essentially the reporting dashboard that you see, what we call the EQIP Entity Portal, or EEP, which you'll hear it called. It is the one-stop shop for enrollment for your both baseline and performance, as well as the final reconciliation. For the purposes of our time here today, we are going to focus on these bottom program data reports. Note that there are additional webinars that are made available on the CRISP website that are specific to like the enrollment process and things up here. So let's dive right in and start with baseline data. So this baseline data, this is going to be available after the enrollment period. And essentially what it does is it looks at the list of NPIs that you have selected for your entity, and it shows volume, the total payment, and the percentile rank for in the baseline period across all of those NPIs. So again, this is a demo view, so some of these numbers may look a little funny. It just sort of is the dummy data that's in the back end. But by default, you will be able to see any episode that has volume. Again, the total volume, the total payments, and the percentile rank. The percentile rank is done in aggregate across all episodes, so you'll see that that number is the same in every single one of these line items. However, entities also have the opportunity to filter just on those participating. I'm actually going to flip to a live view to just see real quick because the data in the demo isn't quite right. But you can see here for this entity, again, you're going to see the volume and the payment and the percentile across a bunch of different episodes. But when you filter to just participating, you're going to limit to those that you're enrolled in, and you're going to see this percentile rank updated just to reflect those that you're participating in. As a note, this info button at the top does provide this pop-up, which translates your percentile rank into the terciles, as well as that what that means for your shared savings. Okay, going back home at the top is going to send us back to our landing page. View performance and savings summary. Let's look into this one next. So in this tile, there are two non-PHI reports, EQIP performance summary and the peer comparison report. By default, you are going to see the EQIP performance summary first. Note, because these are non-PHI, any cell size less than 11 will be masked. This is a good example right here. So you may see this and limited data available. You could see this probably more commonly in the beginning parts of performance years where we don't have a full year of data, but potentially that is an option to see.
All right, Jessica, sorry to interrupt. We have one quick question in the chat. And the question is, how are the terciles calculated?
Yes, it's statewide terciles. So we are looking at the aggregate cost associated with all of your episodes that you're enrolled in compared in baseline to the state. So if you are considered an efficient, low-cost provider and your percentile is in the top tercile, you would get a larger percent of shared savings. But it's where it is state. It is not limited to just those that are participating in EQIP. It is looking at all state data for the baseline period. Okay, so looking at this table, just as a note, and we'll see this in a couple other reports, there's some filtering abilities up at top. So you will have the option to look at or filter on a specific entity or a specific episode, as well as toggle between the different performance periods that are available. So in this table, you will see you have the total episodes initiated by entity, by episode, the total payments, the preliminary target price, and the aggregate target price, which is essentially columns B and C multiplied together to get this preliminary at the end. Again, this is a good place as a starting ground to see what are other people doing, how are they starting in baseline, looking at how people may have performed in that first or the first 2 years we have for the performance period. So peer comparison, this report is intended to allow users to get some visibility into their performance as it compares to the state. So these top two dashboards, the first one or the middle one, are very similar, but it does enable users to compare at a specific episode. So if you can see at the top here, it's going to give the volume as well as some specific breakdowns of cost categories in the episode. I'm just going to walk through this first one as an example. So for AMI, there's 28 episodes with a average cost of $27,000. We're breaking down that $27,000 into 3 buckets: the pre-trigger, the trigger, and the post-trigger amount. And then you can see some numbers about hospitalizations after that initial trigger. And in these cases, you're seeing a lot less than 11, so that number is masked there. But if they had a hospitalization, you would see this number here and the cost associated with it, as well as the average length of stay, again, by episode. Down in this middle column, you can do the same thing, but just limit to one entity, which can allow you essentially to do some comparison, whether for yourself or maybe some other people that are in your market, to share what their numbers may look like to the group. The other thing that this has is a hierarchy navigation feature. So as you can see, when I hover, you're getting this little plus sign. And essentially, if you click this, you can go one step deeper and look at the trigger place of service. So now AMI, it's all inpatient, but let's look at colonoscopy. It's broken down into ASC and an outpatient hospital setting, those same numbers. You want to go up and remove that grouping, you can just press your minus button and that will be collapsed. That same plus feature is available at the entity filtering report as well, which is right here in the middle. At the bottom, you will see statewide percentile details. So the main difference is these first two ones are based off of people that are in EQIP. How are they participating? What are the episodes that they're in? But the statewide percentiles is just that. It is everyone in the state, independent if they are choosing to participate in EQIP or not. You're going to see sort of similar breakdowns of the cost, or sorry, of the categories up at top. But now you see the different quartiles. So again, a good way to go in and maybe look at how my specific entity, EQIP entity number 1, what is my cost and how does it compare to the breakdown of statewide. Now, as a reminder, your target price is based off of your own performance. So you are not necessarily trying to beat a certain percentile, but that percentile comes into play when it comes into your shared savings, and it can give people a sense of where's my opportunity, again, as it compares to what the entire state may be doing. Okay, so I'm going to click the EQIP dashboard up top here, and it's going to bring me back to my homepage. So next is this performance dashboard. This is the mecca of all of our reports. There's a lot in here, a lot to digest. So I'll first orient us to essentially what this looks like, and then we can go and look at each one of these reports one by one. So this taskbar at top, the functionality, as I mentioned, this EQIP dashboard is going to send you back to the landing page. Dex, this button takes you to the Dex landing page. In the Dex landing page, for your entity, users have the ability to download the episode summary file as well as the detailed claims file, both for baseline and the performance years as they become available. Refresh, that does just that. It's going to ask the program to load the most recent data. And data is only currently updated quarterly, so it's not like, you know, if you log in now versus an hour from now, you're going to see a difference. But it's used if people have maybe some browser functionalities. That's probably a first good place to start. Revert is going to look at any filtering that you have or any drill downs that you may have created, and it's going to bring it back to the default view for each of these reports. Print and Excel are export functions. So print is going to give you a nice user-friendly PDF version of the view that you are seeing. So again, if there are filters, that PDF and Excel is going to have those filters in place. And Excel does the same thing, but obviously in a different file. And we do want to note that this whole performance dashboard is a PHI level report. So we do ask users both for the print and Excel functions to handle it and treat the data as PHI, and obviously follow your own internal policies accordingly. And finally, the user guide. This is going to bring up the user guide for this, and it'll give a little bit more detail. I would say it's a good place if people want to have a reminder of like, what do these columns actually mean? There's a lot of different charts in there that helps remind people essentially what this data is intended to show. Okay, so in the EQIP performance dashboard, there are 9 different reports listed on the left here. Just note that you can collapse that if you just want a better view, but most times people just keep it open. Typically, for your first time, we actually do recommend going through these one by one. They are intended to sort of start at a higher level and drill into more details, hopefully having a natural flow of what questions may come up. But obviously, as you are familiar with it, or if you're going into it, you can go in and click whichever report you would like. But for now, we'll start with the target price summary. So again, each of these reports do have filters available at top. So EQIP entity, if you are an administrative proxy that has, for many EQIP entities, you will have this dropdown for multiple entities to see. And you can go in and either see everything in aggregate or just focus on one. For the time being, I'm just going to focus on one. Additionally, this attributed care partner is a dropdown as well. So if you are looking to focus in on just one doctor or a couple doctors, you can go in and check or uncheck that. Again, this is the attributed or the triggering practitioner. That does not mean that they are not involved or other physicians are not involved in the total episode. Episode name is also available. So again, you may have a multi-special entity and say, I just want to focus on my orthopedic episodes. So you can just go in and check those. And when you apply that filter, again, your data is going to be limited to those that you see up at top. The base and performance period, so that is just that. Baseline data is available typically at the beginning or really mid-January of each of the performance years. And then performance data, because it's claims, is lagged, so that becomes available 6 to 9 months afterwards, and that will be updated quarterly, so you can get the most recent data there. And then finally, episode time period. So this is essentially breaking down your base period further to say what month did this occur in. So right now, the demo data is showing performance year 2 having 6 months. If you just wanted to see the episodes that were initiated in January, you can go in and select that. And again, it will limit that data. For the time being, I am going to really just filter on one entity and have everything else be in aggregate. And I'm also going to select a baseline period. Okay. So target price summary is your default. That's what it's going to load when you first log into the performance dashboard. And it essentially just provides an overview of volume, payments, the resulting target price for each episode category, and essentially looking at it in 2 different ways. This top one is by the triggering place of service, where the bottom one is by clinical episode. So if we're looking at this entity, you can see that this trigger place of service is accumulation of all of the different episodes that they are participating in, broken down by site of service, volume, cost, average cost, and your target price. Again, target price is broken down by trigger place of service and episode name, but ultimately, because performance is done at the aggregate level across all episodes, across all NPIs, this sort of very bottom grand total target price is sort of the main end goal that your entity is looking to improve. If we click on a specific one, oh no, sorry, not for this one, but you can go in, yes, sorry, it is this one. You can go in and see the episode details. So I'm going to say, I want to know which 67 osteoarthritis episodes are here. You can see when you click it, you'll get this view episode detail And when you click that, you will get a breakdown of the essentially by episode, this master episode name for each of those that you have highlighted. This functionality, I'll point it out, is available, I think, in like 5 of the total report. So not every single one, but if you're wanting to know, okay, which exact surgery is this referencing? This is the next step to go. And it'll essentially show, again, by episode, by your attributed doctor, this master episode ID, which can go back and be linked to the DEX data. Pardon me. As well as some initial dates associated with just a high level that you could go and see. And we're going to click back and get back into this. And then finally at the bottom here is just essentially a chart comparing the average versus the target price for this. Okay, if we step down one more, we're going to go into the place of service report. The place of service report, start loading for a second, is not showing. So let me pick something else maybe. Has a different time frame. Okay, well, hopefully this will load in the back end. A little bit odd that nothing is showing up right here. But let me talk to it while I hopefully can troubleshoot at the same time. So the place of service report is intended to break down that first trigger place of service and provide categorization of the cost across the episode. I apologize. It's like showing up and then disappearing. Give me 1 second. Okay. I can send a slide out on this. Again, I apologize. I'm not able to show it. Actually, I might be able to. Sorry,
Just
everyone.
should put in the chat episode time period filter. I think that's one of them.
Oh, thank you, Ashok. Filters are important. And our lovely team. Okay, whew. I was a little bit worried there's something I was doing on my end. Okay, so the place of service report is intended to further break down that initial site of service and categorize the cost across the episode. So again, here you'll see by trigger place of service, some similar columns that we've seen in other areas. Volume, what is the percentage of each one of these, which I think is really good to look at if you're looking at like a specific episode. So I'm just going to look at hip and knee replacement right now. What's the distribution that is happening in ASC versus inpatient versus on campus, outpatient? You can see that split, as well as how that translates to cost, and these 3 different categories that we talked about: pre-trigger, trigger, and the post-trigger amount. If you click on any one of these, we actually will break down the cost at an individual facility level. So I'm going to click on it. Oh, why is this showing? And this might just be the demo site, so I apologize. When you click on one of these, a table will appear at the bottom that mirrors this exact columns at the top, but it will give you the specific, in this case, hospital name for these 698 volume episodes. So it's a good way, again, to look at if you want to say, okay, well, you know, my practice does surgeries at, you know, 5 different hospitals all around the state. What's the difference that I'm seeing here? You actually will be able to see that drill down at the facility level. Note some of these, again, it's based off of claims data. So some like outpatient centers or ASCs, if we don't have that flowing through the claims data, it may show up as unknown, but it is, most of the data is available, especially for those that are acute hospital based. Down here at the bottom, this is a relationship between what I have selected up here and the first post trigger setting. So because I have inpatient hospital highlighted, it is going to show me for those 698 cases, where was the next place of care essentially? So most went to home health, but you can see there's a breakdown of SNF, community, and some inpatient hospital as well. Again, same sort of categorizations that we've seen before for these. Okay, sequence of care report. So this report is intended to really walk users through a clear flow of services that the beneficiaries receive following the trigger event and all the way through the end of the episode. So this first column is going to display that initial trigger place of service. The second is going to show the episode sequence. These are a series of letters that represent the sequence. Down here at the bottom, you can refer to as your legend or your key for what these different sequences mean. And then essentially it's going to tell you, again, what is my exact volume associated with this. So I'm just going to pick this first one up here. In the ambulatory surgery center, after that, 4 people went straight to the community, and you can again kind of see the cost and the different categorizations in the time period across those. Some other ones, this is one that had the community and then had home health. So again, you'll kind of see a breakdown. You will note that some of these will get pretty small because they are specific sequences. We will show every unique sequence that has been seen for each one of these. This is one of the reports that also allows that to drill down. So again, if I highlight, and I'm going to say maybe I want to see these 7 that I see an ED visit in there. So I want to see, okay, what specifically episodes were that? You can go in and click the episode detail. This is going to look the same in all of the drill downs, even though their starting point is different reports. I'm able to go in and see what exact episodes, who is the initial attributed physician for it, again, some of the time periods and costs associated with it as well. I would say a lot of times we see people use this functionality when they're trying to then go back into their EHR or link to the claims. That's really sort of that next step of who exactly am I looking for? Okay. I'm now going to click into the provider comparison tool. And this is just that. So it's intended to understand how an individual care partner is performing compared to the entity in its whole. So what you'll see here is 2 similar tables. The right side will show the entire entity, and then users have the ability to go in and select just a single practitioner. And hopefully I will pick one that actually has volume. We'll see. There you go. And you can see specifically what is their volume and what is their cost, again, compared to the group. So it's a good way to get a sense of this. You can also select multiple. So again, if you're in a multi-specialty group, you can select a couple that are similar and see how they are doing in aggregate compared to your entire entity. And at the bottom here, it's going to give that first post-trigger setting. Again, same information, but one that's limited to an individual or the selected care partners up at top and how your entire entity is doing. The next 2, post-trigger hospitalizations and provider and post-trigger hospitalizations clinical, they are very similar. The provider dashboard gives information on inpatient hospitalizations occurring during the episode after the triggering event. So what does that mean? It's a little bit of a word sandwich there. So for those episodes that were initially triggered in the inpatient setting, you can directly say that post-trigger hospitalizations are readmissions. For those that were not triggered, maybe they were triggered at an ASC or something like that, this is saying at some point during that episode, they did have an acute hospital stay. So this top table displays the initial setting of care in which the episode was triggered, and then it highlights the relative number of, again, post-trigger hospitalizations. If I'm looking at this first one in this community, there was, let's say just shy of 300 episodes here, 14 of which of those episodes did have a hospitalization at some point during their episode. Again, as you use your filters up at the top, you can see what episodes that is attributed to, or even what care partner that is associated with as well. Down at the bottom, it's going to give that information again at the care partner level. You can see sort of the breakdown. Again, you'll have the names here, but the same different categorizations. How many hospitalizations did I have? What does that translate to as a rate? What is the count? And I'll just note, here's a good example. Count is slightly different than, or why you would see the number in a post-trigger hospitalization count different than episodes with post-trigger hospitalizations, because that has to do with a repeat beneficiary. So you have 11 total episodes that had a hospitalization, but 12 hospitalizations. That would mean at least one person had 2 hospitalizations in that. And that's essentially how this translates. And it will give you the dollar amount associated with this hospitalizations, average length of stay, again, sort of different information that you may want to know as it comes to utilization of hospitalizations during that episode.
Jessica, we have one question in the chat. I think this was from a couple minutes ago, so we might not be on the same feature, but it says, is there a mechanism to pull all of the patient level detail at once instead of picking just one sequence at a time?
Yes. So the DEX data, which we can speak to at the end, does give the episode summary file. And essentially that is a file that has one episode per one line. So you can see all of that information. The intention for the drill downs in these other areas is to focus on some of the areas that you've been highlighting or looking at to begin with, but the DEX file gives everything. And then there's a further step down after the episode linking file that you can see all of the individual claims that are essentially encompassing each episode.
Thanks, Jessica.
The post-trigger hospitalization clinical. Sorry, I had to reorient myself for a second. So again, this is going to show similar, really the same data, but it's pivoted in a different way. It's essentially grouped by episode category and then the DRG for those hospitalizations. So again, up here, if we're seeing, I guess I'm on hip and knee replacement, they had 7 post-trigger hospitalizations. If you click on this, you can also go and see why did those 7s get readmitted? And you can go in and again see the DRGs here. And this is another one of those reports that allows a drill down. So again, you're saying, okay, well, why are these 3 related to DRG 561? Or who are those 3? Go in and click it, and you'll be able to see these. Again, this doesn't give patient first name or last name. If you want to link back to that, you will be able to look at the master episode ID and compare it to your DEX files. Potentially avoidable complications. So this is actually something that is specific to Prometheus. So you will not see this in the PACES world. You may see a different version of this using some different terminology, but essentially it is grouper logic that's specific to Prometheus. Essentially at the top table, it provides an aggregate summary of the potentially avoidable episode complications and the costs. So again, these first 3 columns, you've seen them all around. They're just there for information, but then you can see the total number of episodes that have been tagged as having a potentially avoidable complications. And again, Prometheus defined potentially avoidable complications. I know there's plenty that work on other state quality initiatives and stuff like that. This is in no way related to anything QBR or things like that. It is a true Prometheus defined categorization. So with that, again, you can kind of see the percentage, the breakdown of costs and everything like that. But also most people are saying, okay, well, what actually is that? Why are you saying it's a potentially avoidable complication? So the second table goes into detail about that. Prometheus tags complications, I believe, into 3 different categories. This one is only showing 2. But within that, you can see the complication type, how they group it, and again, the volume and cost associated with it. This is another one that people want to know exactly who, so they can dive deeper into it. You can do this same drill down function. As you click on this, you can go in and see the episode detail. Next up is quality composite score. So we talked a lot about this in the FAQ. There were questions essentially related to the methodology behind that. And this is the dashboard to track it. So it's really important that people sort of look at this because it is something that can impact continued eligibility in the program. So these top two reports essentially show the same information. However, one is at a percentage, whereas the second shows a specific count for a metric. So for each metric, you will see the rate, your performance, what that translates into as a score. Note that each one can have a max score of 10, and it's based off of the terciles that you fall in compared to the state. So you can see that here. And then it's going to say EQIP probation. And essentially what that means is if any of the three quality metrics fall in the lower two terciles as related to the state, that entity would be put on probation. So in this case, there is not one. And this second table is essentially going to give you the exact numbers. What is the numerator and what is the denominator that relates to the percentages that you're assigned. And finally, we have a breakdown at the care partner. So again, going to give that same information for each of the three quality measures. What is my numerator and denominator, and how does that translate to rate at a care partner level? This will automatically, as you can see, highlight scores that fall into this probationary territory. And while we believe the individual care partner information is very valuable, note that final quality performance is at an aggregate level. So essentially, there's a lot of yellow here that can kind of be alarming, but as it rolls up, you can see that the performance at these three quality metrics is, for this dummy data, is considered to not be on probation and performing well. Again, they have a score of 7, 6, and 8 in them. I'm actually going to skip down to cost breakdown and then go back to reconciliation. So it may be the only one that's a little bit out of order. Cost breakdown. So this is actually one of the new reports that was added, actually from feedback from the group, and it's intended to give more detail on where exactly is the cost occurring in the episode. So again, you can see here, you'll have a highlight of the a roll up of the episodes, and then there's categorizations of cost by claim type. So again, you can kind of see a breakdown here. But one of the cool things is essentially we wanted to have users be able to leverage the filters so they can simultaneously compare three different areas. You can compare the entire entity with a specific place of service and the first post trigger. So if I update these filters up at top, give it 1 second. I can see in aggregate what is my cost for, I'm just pick on knee replacements since I'm here, the 12 knee replacements that were done at an ASC. Of those done at ASC, 2 went to community health, and you can get a sense of the distribution of cost based off a place of service or the initial utility of services right after that procedure or right after that episode trigger. And again, this breakdown down here is all of the different claims. If you want to know details on that, again, the claims data is available, but it's quite cumbersome. But these give sort of high-level categorizations, especially if an entity is looking to hone in on something. I'm just going to pick on, inpatient rehabilitation. This may be a really good place to go in, use your filters, and compare what is that total cost and utility of inpatient rehabilitation as I look at either a specific episode or a specific trigger place of service. Okay, reconciliation. I think this is everyone's favorite report because it tells you exactly what you're doing. So we do want to note that reconciliation is considered preliminary throughout the entire performance year. It is updated quarterly as we get performance data, but there is inflation and GBR standardization that is applied across the year. So you'll see, I guess we say we want people to be aware that these are not truly final numbers until that 9 to 12 month period after the close of the performance year. So this essentially is going to walk individuals through the different calculations or methodology used for reconciliation. And I'm just going to walk through an example because it'll kind of essentially walk you through that. So for this first EQIP entity, If you click on it, it will give you a drop down of the episodes that you're participating in. This entity is participating in 6 episodes with a total volume of 106. Their aggregate target price, again, this is calculated using baseline or 2019, inflated using GBR standardization. There's some methodology on the back end, is 2.4 million. In the performance year, they came in at 1.8 million. So you can see the total savings that they generated is about 600,000. The first step that we're going to look at is, did they achieve savings? The answer is yes there. And then the next question is, did they meet the minimum savings threshold, which is 3%? So that MSR for each entity is listed here. In this case, it's 74,000. This entity far exceeded that. So they would be eligible for shared incentives. Now we're asking, how much is that shared incentives? We look at that tercile. So that very first report that we had with baseline data talked about those terciles. This is where this comes into play. This entity is at the second tercile. If you see down here, we actually list out what that means. They're in the 34th to 66th percentiles, which translates to 65% of the savings being paid to the EQIP entity and 35% being paid to Medicare. So essentially, we do the math here. What is 65% of 300 or 613,000? That's where we're getting this 398,000. And if we follow that flow chart, the next step we are asking in the total payment is the quality performance. So I'm going to jump down to this bottom one, and we're looking at the first EQIP entity, and 5% of their quality, 5% of their savings is withheld for quality. So that's where this 19,000 comes in. That's 5% of 398. And then we look at their quality score. So this one is easy. It was 100%. But if it was 50%, essentially, again, simple math, we're doing what is their percentage times their quality withholdings, and that's going to relate to the earned quality adjustment. Again, this case, they earned everything. So with that, we're gonna add that the quality adjustment back into the participant savings share. So we get 398. Now for years 2 and on, those that are eligible for incentive payments are required to offset their prior year DIS savings before a check is earned in that year. So in this case, for PY1, this entity had a negative or DIS savings of 133,000. We're going to account for that or offset that DIS savings. So their new shared savings is 299, or sorry, 165. And then the other thing that we're going to do in that last step is CMS every year gives us that 25% cap. It is the max state is allowed to pay out for each group. In this case, it's 299. Since 166 does not exceed that, that's where they get the 165 as their final check. So again, it's a lot of math, but it's hopefully really step-by-step and walks through that sort of flow chart that we have for the methodology and final savings. If there's any questions about this, obviously this is something that Chris HSCRC is happy to review in detail. And then with everything, you also have the opportunity to export this in Excel or PDF. I'd say this is one we see primarily a lot of people exporting because it is the final numbers. Everyone wants to know how they've done. So with that, that is all of my prepared material in this reporting suite.
We have one more question in the chat, Jessica. Victoria asked, could Chris provide more information on the methodology regarding the updates to the CMS incentive cap and GBR standardization rates applied to the final PY2 EQIP reconciliation values?
Yeah, I would say I'd probably point you at least to this point, and we can send it to you directly to the specifications and methodology guide. It talks about those. A lot of these are coming directly from CMS. So essentially, as the state of Maryland gets more information, we apply that. There's certain information that we don't know exactly January 1, how it's going to pan out throughout the whole year. So those are essentially added in each year. We will note that the CMS cap is something that we typically don't get right away. So typically when the data release, the final reconciliation for the performance year is released, Chris HSCRC is using an estimate. It's not just nothing there. We are using our best information that we have at hand, but we are waiting for CMS to essentially give us final numbers. Once that's received, the portal is updated.
Okay, we have one other question in the chat. Cindy asked, on the cost breakdown report in the cost by claim type section, inpatient rehab. Sorry, let me load for you. It said inpatient rehab is listed. If you want to set the first post trigger filter to IP rehab, there is not a choice for that. Can you filter for the first post trigger to be IP rehab? I don't know if that's
I will have to look at that. I think so. I would say there's probably an explanation I can give to this. So cost by claim type, these claim types right here are CMS defined claim types. Typically from case mix data that is going to say, you know, this is a specific claim, we're going to categorize it as this. So it does not, you won't see an equivalent necessarily in the first post trigger. So I do not believe first post trigger inpatient rehab is available. I'd have to double check. I could probably look at that. And Cindy, I'm happy to schedule some time one-on-one with you to look specifically as it applies to your group. And I don't know, sorry if there's any H metrics people on the call, if they want to correct me or anything, but that might be something we have to address offline and look into in further detail. The other thing that I apologize, I stopped too early, wanted to address was DEX. And we mentioned this, and again, this is a way to tie back some of that specific episode detail into it. When you're looking at your DEX in the, when you click on DEX, sorry, from your homepage, you're going to essentially get to this DEX exporter. And it's going to give you the ability to extract Excel files. We will note that some of the size of the data, it's recommended to actually use some other programming. Excel might not actually be able to ingest and digest that. So please keep that in mind as you're looking at this. It really is dependent on the size of your entity. But essentially it is going to, we always recommend people to first download this documentation. And again, everything's a little bit, nothing is in the demo site for this because it's claims data. But download the documentation and it's going to have a specific guide for each one of these categorizations. The download episode file, that is essentially, sorry, download episode summary, that is essentially the file that has one line per episode with probably at least 20 different columns associated with it. So if you're looking for that single extract, that's really the place to start. The download claims detail is going to go one level more in detail. So it's gonna, if you're now saying, okay, I kind of have information at the episode level, but I want to know exactly which claims are in each one of those, this is the extract file for that. There's many different extracts in that based off of claim type. You see a part A, part B, some physician costs, things like that. So please use the download documentation guide to help you better understand the differences between those files. It also has a linking file that will essentially say, this claim is linked to this episode. So all of that is available for people to do some further analysis. And the physician report provides a document at each attributed care partner, sort of a roll-up of performance, volume, cost by episode, things like that. That's all available. I will note that this data download is going to be the most recent data download. So for people right now in PY3, this is going to be the first quarter of PY3 data. But if you're looking for baseline data or prior years, you would want to click this historic data. And again, apologies, the demo site isn't going to have claims data loaded, but it will have those same extract files available for prior time periods. And that's essentially what the DEX does. Any questions related to reports? Or really anything? We're open to all questions.
Hi, Jessica. I just want to follow up for the EQIP specifications guide that you mentioned. Is there going to be an updated one for next performance year? Because I think the one on the website is for this current year.
Yeah, we're working on it. We're hoping it would be out actually by this, but it's like in the very final end of finalization. But yes, there will be one. We're noting that right now, obviously, there's a lot that's referencing Prometheus. So we know that there's some specific stuff that needs to be updated. I think the core of everything that has been brought up as far as policy changes hopefully has been addressed in a subgroup, but we definitely understand the need to put it all in the specs guide. But yes, those will all be done, and we will let people know when they are available on the website.
Okay, thank you so much.
Mhm. Okay. Well, we want to really thank everyone. Obviously, Olivia, Crystal, thank you all for such an amazing presentation. But also, Medkai, Jean, this really came out of a request from people either asking sort of similar questions or saying, where can I find this? We're happy to do sort of iterations of this as we feel like they're available, but really want to essentially give people resources and materials as they need it. Always want to point people to the CRISP inbox, Medkai and CRISP's website as places to reference. But essentially, our ears and eyes are open for any questions that may come in. And if we feel like it's something that should be addressed as a larger group, we'll of course incorporate that into upcoming agendas for subgroups. That's it. Jean, you have any closing words for us?
I think we're good unless Olivia or Crystal, you want to add anything, or are we good?
All good. Thank you, Jessica.
All right. Well, everybody have a great weekend.
Everyone.
Thank you.